Next up, with our Pqi Clinical Overview is Derek Gorey. Derek will speak about the Pqi that he co-wrote in collaboration with Julianne Orr on the management of Abemaciclib-associated diarrhea. Derek.
Good afternoon, everyone, and thanks for the introduction. So I'll dive right into the Pqi. Abemaciclib is one of the most recently FDA-approved cyclin-dependent kinase inhibitors. It's used for the treatment of hormone receptor positive and HER2 negative metastatic breast cancer. There are others in its class currently. There are some major differences between the different cyclin-dependent kinase inhibitors. Specifically has to do with the adverse effect profile. Ribociclib and palbociclib, the other two, have a higher risk of neutropenia, whereas abemaciclib has a lower risk, but with that lower risk, it also has a higher risk of diarrhea associated with it. In clinical trials, the diarrhea usually appeared around 6 to 8 days. This is quite different from a lot of our other oral chemotherapy agents, which usually come after the first or second dose. So that is something that is quite different and patients need to be educated on. One important thing though is that this diarrhea can be managed, especially avoiding those dosage reductions or interruptions for this patient population. In terms of the Pqi process, once you receive a prescription for abemaciclib, it's important to look for an appropriate anti-diarrheal medication. Most of the time you'll see loperamide. Usually you wouldn't use the diphenoxylate or atropine or the tincture of opium up front. So when you're really looking for that anti-diarrheal, loperamide is usually going to be that one that will be available to the patient. If they don't have an anti-diarrheal, it's important that you encourage the patient to pick up an over-the-counter prescription and keep that well stocked, since this does appear a little later than normal oral chemotherapy agents. As we'll kind of talk about as we continue, you'll want to counsel the patient on specific compliance and when to administer and some different side effects that can be seen with each different type of anti-diarrheal agent. And then for the patient, we would usually follow up within that first week of therapy. As I had mentioned, the diarrhea usually appears around days 6 to 8. If loperamide alone doesn't control the diarrhea, you can contact a prescriber and have them add diphenoxylate and atropine or another anti-diarrheal agent. But if the patient is having severe diarrhea, it's best to have them become admitted for fluid and electrolyte administration. In terms of the agents that I've kind of already mentioned, loperamide is usually the go-to since it is over the counter. The typical administration is you take 2 caplets, which is 4 milligrams, and then 1 caplet every 4 hours until you have a diarrhea-free period for about 12 hours. If there's no diarrhea after that, they can stop the loperamide. The recommendation is that patients shouldn't exceed 8 caplets per day. If it does not improve within 24 hours, the patient should contact their healthcare provider. One thing the healthcare provider can recommend is that patients take up to 12 caplets per day, but this is only recommended under medical supervision. So that is very important that a patient know that. The other agents, diphenoxylate, atropine, are prescription only, so physician would need to be contacted. They can take 2 tablets 3 to 4 times a day with a max of 8 tablets. And you can alternate this with loperamide to achieve around-the-clock coverage. Common side effects that come about with this medication is dry skin and mucous membranes, tachycardia, urinary retention, and hyperthermia. And although pretty uncommon, respiratory depression can occur due to the diphenoxylate component. One agent that's not seen as often as the first two is tincture of opium. This is also a prescription-only medication. And the directions are shown here. And similar side effects, CNS depression, drowsiness, urinary retention, constipation, nausea, and headache, and also uncommon but respiratory depression can occur. So when going through the different grades of diarrhea, if it's grade 1, we usually don't have to have a dosage modification. Grade 2 is where it becomes possible that there might need to be a dosage reduction. With the first episode of having diarrhea for greater than 24 hours, you would just wait, hold the dose until it's less than grade 1, and then you would just resume the same dose. If it happens again though, you would dose reduce to the next lower dose. And then if grade 3 or 4 toxicity occurs, you'll suspend the dose until it's less than grade 1. And then again, you would reduce to that next lower dose as well. And then in terms of patient-centered activities, patient compliance is a big, important counseling point. We would encourage that patients take this at the onset of a loose watery stool and every 2 hours until it resolves. The medication only needs to be taken for loose watery stools, so that's a big counseling point. If patients are still having formed stools and they're not watery, but they are more frequent, they don't need to take loperamide or their antidiarrheal agent, but if they become watery and very loose, that's when we would really expect the patients to take their antidiarrheal medication. Important to tell the patient when to expect the diarrhea, since it is a little different from other chemotherapy agents. Make sure they're staying hydrated with 6 to 8 glasses of water, clear liquids, soup, or sports drinks, and then when to have the patient call their provider. And that's especially within 24 hours of the onset of diarrhea and it hasn't improved. And then ultimately, diet is very important, avoiding those greasy, spicy, or fried foods, avoiding milk, caffeine, alcohol, and higher fiber vegetables. Tell them to eat smaller, frequent meals that may help the BRAT diet. And then, as I had mentioned, staying hydrated throughout the day. And with that, I'll open the floor to questions.
Thanks, Derek, for that great overview. I want to just start off by asking what you feel is the main takeaway from this PQI. What are the most valuable points that our members should go home with?
I think some of the most important points from this PQI include that this is a very pharmacy-friendly issue that we can help physicians manage. By doing that initial medication review to make sure that patients have an antidiarrheal medication, making sure that they're not already taking like a stool softener or a stimulant that may increase their risk for diarrhea. Important to educate them on when this happens. That 6 to 8 day mark is a lot different than a lot of the normal medications that patients take. Usually they have diarrhea 1 to 2 days after starting. So making sure they know that this might be delayed. So definitely make sure that they have an antidiarrheal on hand when that, or if that occurs. I think those are probably the 2 biggest points, and then just making sure they're compliant with their antidiarrheal medication while they're taking Abemaciclib.
That's great, Derek. Thank you so much. And if anyone has any questions for Derek at this time, again, feel free to utilize the chat box Q&A or raise your hand, and we can allow you to speak. And if not, feel free to ask a question throughout the presentation, and we can always circle back with Derek when the presentation finishes.